Okay, so I'm just going to talk a little bit about antibiotic stewardship. So there's a staggering number of New Zealanders get an antibiotic every. It's 50% for adults. And the Growing Up in New Zealand study, by the time the kids got to 5, I think 95% of them had had one or more courses of antibiotics. That's absolutely massive. Given that most antibiotic prescribing in primary care is discretionary, not mandatory, it's a really good thing to keep hold of. You know, most people don't need antibiotics. That's the default setting I go in with. So there's rising resistance. There is I've done quite a bit of work on delayed antibiotics. I actually think now we should just be saying no. Come back, we'll see how you are, or watch out for if this happens, then maybe you can have some antibiotics. Because the problem with delayed antibiotics, half the people go and fill them anyway. The back pocket prescription. I think we need to offer reassessment. I think that's better clinical practice. PHARMAC are doing a small public campaign at the moment. There's this issue of C. difficile, which, interesting, in the UK and other places kills people. It doesn't seem to kill people. But I'm going to talk about our Augmentin free office. And I had one patient who ended up on a ventilator with C. diff. So it does have some dangerous things. There's the whole issue of gut bacteria, and I used to think probiotics were rubbish, but the research does seem to be suggesting they may have some role. The problem is you look up the study and is this the yogurt that's available in my supermarket, or is this some weird pharmaceutical grade yogurt, and I can never quite tell. So I think it's not quite practical for everyday use now. So that's the issue. Antibiotic stewardship is a big thing for PHARMAC. They're quite concerned about that. And this is the thing, primary care antibiotics are mostly discretionary, not mandatory. By the time they get to these guys, they're mandatory. Well, unless they've got chronic sinusitis, but with a lot of the stuff. And I think you have to remember what world you're living in. We're now suggesting shorter courses and higher doses. People don't have to finish the course of antibiotics. The public think they do, but actually that just creates more resistance. Well, take the scenario, you give 5 days, you give 10 days. Well, what's happening to the person's bacteria in the additional 5 that he's getting? And we make up the duration of antibiotics. That was quite a revelation to me when a colleague said to me, we make up the duration. I say this to the registrars, and they say, no, we don't. Okay, who does 3 days? Who does 5 days? Who does 7 days? Who does 10 days? And different hands go up, and I say, see, you make it up.
Strep throat.
Eh?
What about strep throat?
Strep throat's one of the few things. There's very few things where strep throat's the only one. Even that's made up, actually. We don't even know if that's... That seems to be what eradicates the strep, but it's not 100% either. Medicine, unfortunately, is not as easy as we would like to think. So as I say, antibiotics are discretionary. There are some things, strep pharyngitis, some otitis media, obviously pneumonia, and then this is probably the take-home point for me anyway, and I'm going to ask these guys to chip in as needed, severe symptoms, because the problem with all the primary care research, you don't get into a primary care otitis media trial if you're very sick. So we don't know what to do with those people, and I think if someone looks very sick, you give them antibiotics. You don't want them ending up with a mastoiditis or a sinus abscess or something. And this is the other thing. So most antibiotics in New Zealand are given for symptoms, not a bacterial diagnosis. I have a colleague in the UK who suggests we should only give antibiotics if we have a microbiological diagnosis. Now, how would that be? Now, of course, with cellulitis, you're not going to have one, eh? There are some things in primary care, and if you stick a swab up somebody's nose, well, what does that mean? Or if you even stick it in their ear, what does that mean? You grow bacteria, but is that the organism? And that's the problem. We're dancing with symptoms, not with diagnoses. And the longer I'm in medicine, I realise that it's all about probabilities, basically. The probability that this person has something that might get better from an antibiotic. And that, of course, is hard to teach. You're a second-year registrar. That's quite hard to get across to you, that you have to dance with the probabilities. You can give antibiotics to everybody, but you want to be a good doctor. That ain't good medicine, If you give antibiotics to nobody, that's not good medicine either, So it's trying to find that balance in between. Hopefully by the end of today, with our various inputs, we will get into that. So I'm going to talk about acute sinus symptoms, and this comes from the website BMJ Best Practice, which if you are a teacher of Auckland University students, you get free. You can get your own subscription. I think it's the best of the electronic websites. I do the common cold chapter for them, and that's not a conflict of interest. I give my fee back to them basically because it's too hard to cash it. But it's nicely set out, and they have the evidence links off it. So this is sort of the thing we see: bit of facial pain, bit of nasal discharge, possibly some dental pain, nasal congestion. Okay, and in our setting, primary care, it's mainly viral. Rarely people get very sick, and my only experience with somebody who's very sick is the son of a friend of mine who was in Starship for 4 months, I think, with one of these ethmoidal type things. I don't know where it was, but this kid was really sick and he was in hospital for 4 months. That's what I want you guys to give us a word or two about. Is it viral or is it bacterial? It isn't easy, and again, I'd be interested. I understand even rhinoscopy doesn't particularly help you. We think these guys have got the gear, but actually, if they were in our setting, even with all their gear, they might have the same sort of trouble. So it is difficult. There's a bunch of symptoms. Nothing's diagnostic. Nothing's diagnostic. That would be an important take-home message. Okay, so this is the thing. This is interesting. This is the old thing. Greater than 10 days may indicate a bacterial cause. Imaging's not required unless it's very complicated, but then you would refer the patient anyway. Usually self-limiting and symptomatic therapy. Antibiotics only recommended in selected patient groups unless they are immunocompromised or with severe disease. So if you had a patient on, I'm starting to be aware of these disease-modifying agents in people with rheumatoid arthritis, that it actually does damp down. These people start getting nasty pneumonias, and so you might be a bit, you might see what drug they're on, and if they're on methotrexate, well, you might want to think of an antibiotic in that situation. So this all comes from the BMJ best practice. You can get a subscription to it. I don't know how you do that or what it costs, but the easiest thing is to teach Auckland University medical students, and you'll get a free one. Okay, so this is how they have a summary of the, and it's lovely. You just sort of see, this is the first line, second line, third line, fourth line. Now, when I went through this, the evidence sort of stops here. This is just, and you have to remember, when there's no references over here, they're sort of making it up, but there'll be a consensus of people. There'll be a whole bunch of people who are making this up, who have some experience. But that still doesn't get you away from the fact that it's just people's opinion. And even the cardiovascular guidelines, only 40% of it is evidence-based. You get down to ENT, and my guess it's probably 10% evidence-based. I don't know. Maybe was that
it's probably an exaggeration.
Exaggeration. Okay, which is a bit, we like to think we've had antibiotics since 1941, and I'm going to talk about pus coming out of the ear later on, and we still don't know what the best treatment is. Cochrane reviews. One of the problems, of course, is there's just not enough research in primary care. These common things we should have completely under control. And in the UK, there are some really good, they've got some fantastic things going on there at the moment. The amount of money in primary care research is unbelievable, and they're starting to knock off these things. I just saw a study the other day about whether you should emollient baths, whether they help eczema or not, don't make any difference. It's all that fussing and bother that parents go to. Waste of time. Really important negative study. Good to get negative studies. We just stop doing it. Poor old parents don't have to sort of feel bad about not popping their kids in a bath with bath oil. Okay, so here's the first thing. So supportive therapy, decongestant. So xylometazoline. I've been trying to get PHARMAC to fund this because I think it would give us an alternative to giving antibiotics for colds. PTAC came back and said, well, there's no evidence it's effective. And my reply to that is, we're giving antibiotics which we know are not effective. You only have to stick this stuff up your nose and you know it works. Anybody who's ever put that in their nose when they've been congested will start breathing instantly. It's a very powerful thing. And I think the research, it's not great, but it is. But anyway, so that you have to pay for. And they actually suggest kids. I would never give it to kids, basically, but 2 to 5 years. Usually kids under 5 you don't give these things. But this was a bit of a surprise to me. Lower dose stuff, and I don't know that we have that dose here in New Zealand. We do have this dose. So adults you can give. The one downside of it is you do get bleeding noses. I know when I use it I start to get a blood nose, and there's a bit of a pain when that happens. This is my favourite drug, not recreationally but professionally, pseudoephedrine. They suggested going up to about 200 milligrams a day. I would be cautious because there was a decongestant drug called propylalamine some years ago. Case control study showed it caused stroke. So I don't know whether that's because it has a pressor effect or there was just something about that drug. And actually there were some young women who had strokes like in their 30s. So I'm a bit twitchy. I don't give it to very elderly people, and they're not usually, it's usually the 25-year-old who wants to get back to work. And as you'll know, this has to go on so I never give more than 30 to 60 milligrams a day, and I only give in the morning. If you've ever taken this stuff at night time, it'll keep you awake during the day. But when I get a cold, I take a bit of this and I get back to work. Now the problem with this is it requires a controlled drugs form, which is a real pain you'll be aware of. And the only way that's going to be reversed, because I talked to MedSafe about this because I was trying to get this made, taken, because I mean methamphetamine is not made out of this stuff anymore in New Zealand. It comes in across the border from China or overseas, so it's not coming. It's coming in as methamphetamine, not as pseudoephedrine. In most cases, as far as I know, to get this back to be a regular prescription is going to require an act of Parliament. It was made a controlled drug by regulation, which you can just do. You can make something a controlled drug, unmaking a controlled drug. And the 8 tablets I give to my local accountant isn't going to end up as methamphetamine, you know. I mean, it's ridiculous. And I have to say, I'm a bit disappointed in my colleagues some years ago who pushed to have it as a controlled drug, because it's probably the only thing that's effective when you've got a cold, other than that, for your symptoms, or ipratropium. So yeah, we're stuck with it. So it's a big procedure. Takes 5 minutes to do that. You've got to scan it, put it in the book, you know, all that sort of stuff. So it's a real pain, but it is effective. And if people want to get better today, that will make them feel better today. Intranasal steroid is, I've sort of looked at some of the evidence for this. It ain't great, but it actually has to be relatively high dose. In the UK, they use mometazone. My translation would be 50 milligrams twice mane or twice a day for up to a month. If you've got a patient, you've got acute sinusitis, and there are a few trials on that. They're not wonderful. Ipratropium is quite good for rhinitis. There are some trials on that. Again, they suggest in kids over the age of 6. This is the strength we have in New Zealand. They have a different strength in the UK. We only have one strength here. That does reduce rhinitis. Doesn't reduce congestion though. Quite a good article from an Australian group in the BMJ a few weeks ago on the different cold remedies, and what they came up with was this and the decongestants. Beyond that, it's just time. And I think the key thing with patients, what I do with the colds, is I say the cough's going to last a month. You lower the expectations, because people come back in 2 days and they want an antibiotic. You know, you think, well, that's nuts. Do you have a life-threatening illness? Do you want a life-threatening drug? Because there's 1 or 2 people who die every couple of years from the antibiotics we give, not the ones these guys give people, the ones we give people, the doxycycline. I can remember back in the early 80s when cotrimoxazole was commonly prescribed, there were 10 cases of bone marrow aplasia a year and 2 deaths. And I still get anxious today when I prescribe cotrimoxazole. I think I tend to only give it to young kids because I think their bone marrow is probably a bit more flexible. But and we don't see it, of course, now because we hardly ever give the stuff. It's sort of gone off the radar. But antibiotics do kill people, not through anaphylaxis, it's through bone marrow failure, liver failure. So they're not candies, as I say to my patients. And do you think you have a life-threatening illness with your cold? Do you want a life-threatening drug? You know, I think sometimes we've got to pitch it. Sometimes our sales pitch has to be, you know, you don't need this, even though the last 5 doctors gave it to you, which of course is very difficult if you work in a clinic with doctors who give, or nurse practitioners, which is becoming an issue, who give antibiotics and you don't want to give them. So you have to get your colleagues on the same page. Intranasal saline, I think this is getting into the magic area in this condition. Probably not in, I think, for the chronic sinusitis, that's probably quite good. But that, again, there was no evidence on this one, so I think it's just, have you heard of GOBSAT, good old boys sitting around tables? So that's how guidelines are made, GOBSAT, good old boys sitting around tables. There's good old boys and girls now sitting around tables. So that's how guideline, I've been on guideline commission, that's how it happens. The strongest personality wins. You'd be horrified, I think, if you figured out, if you knew the politics of how some of these guidelines Why we have a 15% threshold, that was one personality on the guideline group in New Zealand, so who decided 15% was what we should do. That's how it happened. Strong personality won. Mucolytics, guaifenesin is really something which is a complete absence. I was a bit disappointed to see it in there, but if a patient wants to try it, the thing with the over-counter things is probably none of them work other than the xylometazoline for any of these sort of conditions. And if the immune system is okay and not severe, then you might want to give antibiotic therapy and then all the other things, and/or I'm not sure you guys would want to be seeing people who may have acute bacterial sinusitis. It wouldn't be. But if they're not particularly severe. But this thing's interesting, the second sickening. Now, I've been tracking this back because I want to know where it came from. You know, this thing, you get sick and then you get better and then you get sick again and then you get antibiotics. There's no randomized trials doing that. You can imagine you just probably couldn't assemble enough people to do a randomized trial. And I go back and it refers to a guideline paper, a review paper, and then it goes back to another guideline review paper. Then it goes back to no primary research. As far as I haven't been able to find any primary. I was saying to Sumit on the way in, you go back to these things. I did a thing on episiotomy in low-risk women, and it all went back to 1926 when somebody decided that routine episiotomy was a worthwhile thing to do. Some guy just made it up in 1926. And my guess is with this, somebody in the 1940s probably made it up. It may be completely true, but there's no empirical evidence on it. I don't know what you guys know about it, but it's sort of been interesting just chasing it back. And I've chased it back as far as I can go. Or if they're very toxic, now that's obviously a clinical decision, but I'd say somebody who's tachycardic, got a fever, and they're looking sick, you might want to give an antibiotic straight away and or refer them, just knowing. And I think if somebody's had symptoms and they're not getting much better, greater than 10, this is the BPAC stuff, severe symptoms that last for more than 3 days, well, do you want to sit on somebody with severe symptoms? I don't know. Again, you're dancing with the probabilities. Dancing something you've got to be able to willing to do in primary care. Okay, so here's the antibiotics, so 500 to 1,000 milligrams TDS for 7 days, so quite a big dose. It is 7 days still, but again, that's based on, there have been some trials in acute bacterial sinusitis of 3 days using cotrimoxazole, but this is clearly the safest drug to use. And I think with the oral one, you tend not to get the anaphylaxis. My feeling is anaphylaxis tends to occur with injectables, usually. The severe anaphylaxis, I've only seen one in my lifetime. Again, hard to get that. Doxycycline, remember kids over 12 because of the teeth staining, and it's 200 milligrams stat on day 1. And then, so if you want to have a look at the BPAC thing, a lot of things now with doxycycline, and again, I don't know how evidence-based it is, but it's 200 milligrams stat and then 100 milligrams. Then Augmentin if not getting better, and referral to ENT. And I like to talk about our Augmentin-free office in our clinic. So in our clinic, you can only give Augmentin if you get the permission of a colleague, which is quite a nice test of, or occasionally I ask medical students. I've had 250 medical students, and I've turned to them and said, I'd like to give Augmentin, can I do it? And both of them said no. So I gave flucloxacillin, but here's the liberating thing. Flucloxacillin, if you've got my gem, you can now give with food. 1,000 milligrams TDS with food. No more torturing the public with 500 QID. If you've ever, I remember I've tried taking flucloxacillin 4 times a day on an empty stomach. The only times I ever remember is when I got food in my stomach. I think, oh damn, I've forgotten again. And literally days would go by before, trying to take a medicine on an empty stomach, unless you use your mobile phone and set the alarm, you've got to be pretty. Anyway, this lady had breast cancer, she had surgery, she did get a staph infection, so possibly not a bad thing, but maybe fluclox. Anyway, she got a C. diff, ended up on a ventilator. I have another man who made it to 90 and finally died. When he was 80, he got given Augmentin, he got liver failure, ended up on a ventilator. Now, I've given a lot of antibiotics in my career, and this is the only one that I've seen that happen to, okay? My penicillin anaphylaxis wasn't me giving it. I inherited the patient in the intensive care unit, unconscious and sadly dead, but we kept it going for a few days. So Augmentin-free office. So it's the clavulanate that's the problem. And the problem is the dose. If you want to give a high dose of Augmentin, you have to just give a low dose of Augmentin and top it up with amoxil. Otherwise, you're giving too much clavulanate, and it'll wreck the gut. The diarrhea. It's a magnificent laxative, clavulanate, and the dose is pretty high here. It's a bit lower in other countries. So if you're going to double the dose of Augmentin, don't give twice as much Augmentin. Give regular Augmentin and give extra amoxil. But I've never had to be in that situation, but this is Carol. She happily showed her photograph there, so she's getting into her 80s now. Which antibiotics? Duration's unclear. Duration of symptoms. No improvement. This is BPAC stuff, changed the antibiotics. So, okay, so that's acute sinusitis.